We're now going to move on to the diagnosis of achalasia and EGJ outflow obstruction and how that's dealt with in Chicago Classification 4.0. Leading the discussion here will be Dustin Carlson and Arian Bredenoord. By way of background, Dusty is an assistant professor of medicine at Northwestern University in Chicago. He is a master of FLIP, the functional luminal imaging probe, which figures into this discussion in a major way. He's also a former Northwestern Super GI Fellow. Arian is a professor of medicine at Amsterdam Medical Center in the Netherlands. He is well known as an architect of the Poema Achalasia trial and also the third mastermind of the Chicago classification.
Thank you for listening to this lecture on diagnosis of achalasia using the Chicago classification version 4. My name is Arian Bredenoord and I'm a gastroenterologist in the Academic Medical Center in Amsterdam and part of the Chicago 4 group. Here are my disclosures. Achalasia is characterized by a progressive destruction of ganglion cells in the myenteric plexus. It leads to an absence of peristalsis, dysrelaxing lower esophageal sphincter, and as you can see on the barium swallow, a distended esophageal body and stasis. Typical symptoms of achalasia are dysphagia, weight loss, regurgitation, and chest pain. And the gold standard for diagnosis is manometry, where you'll find aperistalsis and lower esophageal sphincter dysrelaxation. Since conventional manometry has been largely replaced by high-resolution manometry, the Chicago classification will be used to diagnose esophageal motility disorders. The first version was the result of an international HRM consensus meeting in 2011 in Ascona and has evolved since. The Chicago classification version 3 was the most recent one, and as you can see in this hierarchical system, achalasia is on top. It is characterized by an integrated relaxation pressure above the upper limit of normal and 100% filled peristalsis or spastic contractions. The IRP is the most important parameter of high-resolution manometry. It is defined as the lowest average relaxation pressure for 4 continuous or non-continuous seconds in the window between the onset of the swallow and the arrival of the contraction wave in the distal esophagus. An IRP of 15 in a 4-second window has been selected because the 4-second window has been shown to be the result of an optimal combination of sensitivity and specificity, and so the best diagnostic yield. And so if the IRP is higher than normal, so above 50 millimeters mercury, and there's no peristalsis, we can say that there is achalasia. High-resolution manometry is better than conventional manometry in the recognition of achalasia. Here's the results from a large French study where patients were randomized to undergo either conventional manometry or high-resolution manometry at the time of diagnosis. A year later, an adjudication committee decided upon the final diagnosis, and the study showed that achalasia was more often correctly diagnosed with HRM. Other parameters that can be important in diagnosis of achalasia are the recognition of intrabolus pressure. There's 2 types: panesophageal pressurization, which is defined as simultaneous increases in pressure in the entire esophagus, as you can see on top. And then there's a compartmentalized pressurization, where a propulsive contraction squeezes a bolus in between the contraction and a non-relaxing lower esophageal sphincter. Another important parameter is the distal latency. The distal latency is the time between the onset of the swallow and the contractile deceleration point. The latter is the moment where the contractile front velocity decelerates when arriving in the distal esophagus. And so if the distal latency is shorter than 4.5 seconds, we call this a premature contraction or spastic contraction. There's 3 different subtypes of achalasia. There's the type 1 achalasia, characterized by absent peristalsis and a non-relaxing lower esophageal sphincter. We call this one the classic achalasia. There's the type 2 achalasia, where there's a non-relaxing lower esophageal sphincter and these panesophageal pressurizations. And then there's the type 3 achalasia, which is characterized by a non-relaxing lower esophageal sphincter and these premature or spastic contractions. And so we sometimes call this a spastic achalasia. It's very important to make a distinction of these different achalasia subtypes because they have important prognostic value. Here's data from the European achalasia trial, where you can clearly see that the success rate with time is higher for type 2 achalasia than for type 1 achalasia, and both do better than the type 3 or spastic achalasia. And so the type 3 or spastic achalasia has the poorest prognosis, the worst response to treatment. And so differences in manometric subtype can determine which treatment to select. Just very recently, the Chicago classification 4 was introduced. The diagnostic schedule for Chicago 4 is a bit more complex than it was for Chicago 3, but as you can see, achalasia is still on top of it, where you can start with an abnormal median integrated relaxation pressure and subsequently absent peristalsis or premature contractions, leading to a diagnosis of achalasia type 1, 2, or 3. There's a few differences made compared to Chicago classification 3. One of them is that if there's an IRP above 15 in the upright position, this is considered also indicative of achalasia. Now, upright positions were not mentioned in Chicago version 3. There's also an introduction of the term inconclusive achalasia diagnosis. This consists of subjects where there's absent peristalsis, but the IRP is borderline, so not above 15. And there's some remaining peristalsis, you can see in the image below. In these cases, additional testing may be required in the form of time barium esophagram or FLIP. FLIP, or endoluminal functional lumen imaging probe, is a balloon filled with saline placed at the esophagogastric junction. Then different balloon volumes are created by infusing the balloon with saline, and then you can measure the EGJ distensibility, which is the surface divided by the balloon pressure required to get that surface. And so the more you fill the balloon, the more EGJ is opened. And so you can see from this study from Rohoff that the distensibility is higher in healthy subjects compared to successfully treated achalasia patients. And this is more higher than the unsuccessfully treated achalasia patients. The untreated achalasia patients have worse distensibility. And here you can see how that looks like with the balloons. So the healthy volunteers, the balloons opens very easily. Same in the treatment success, but in subjects with treatment failure and particularly newly diagnosed, it is a lot of pressure is required to open that balloon and thus to open the EGJ. Now there's sometimes these patients with inconclusive achalasia. And Pons described a couple of these with typical symptoms of achalasia, aperistalsis, but an IRP of less than 15, and often a low basal LES pressure. Here's an example of such a patient. When you perform FLIP in these patients, you'll see that there's a decreased distensibility, similar to achalasia, and very different from healthy subjects, which means that the ETJ is difficult to open. On time-barium esophagram, you often find stasis. Now, treatment with pneumatic dilation or myotomy increased distensibility and improved symptoms in these subjects. And so, conclusion of this paper is that patients with absent peristalsis and a borderline IRP can also have achalasia and respond to achalasia treatments. And so this is one of the changes in Chicago 4. So just to summarize this, the changes are the IRP above 15 in upright position is also indicative of achalasia, and there's the inconclusive achalasia on manometry, where there's absent peristalsis but borderline IRP, and some remaining peristalsis. And in those cases, you do additional testing in the form of time-barium esophagram or FLIP to search for the same cases Pons described. There's a category of patients that are initially diagnosed with idiopathic or primary achalasia, and they turn out to have achalasia secondary to cancer. We call this malignant pseudoachalasia. They can usually be identified with EOS or CT, but you don't want to do these additional testing in all your subjects with achalasia. So the question is when to do additional diagnostics, and basically how to identify patients with higher risk of malignant pseudoachalasia. So what was done was a comparison of the clinical and diagnostic features of a very large group of achalasia patients and patients that later had the diagnosis of malignant pseudoachalasia. Now, the diagnosis of pseudoachalasia was sometimes made with EOS, with a second or third endoscopy, CT scan, or sometimes even during treatment. And the type of malignancy is heterogeneous. It can be adenocarcinoma of the esophagus, squamous cell carcinoma, but also carcinomas of the cardia, pancreas, or paraneoplastic syndromes. The malignant pseudoachalasia patients seem to be older upon comparison. They had a shorter history of symptoms. They usually had more weight loss, and there was more often a difficulty passing the esophagogastric junction in these patients. And so this led to the identification of risk factors being age above 55, symptoms less than 12 months, weight loss of more than 10 kilograms, and difficulty passing the EGJ. And so if you compare achalasia with pseudoachalasia for the number of risk factors, you can see that if subjects have 0 or 1 risk factor, they never have malignant pseudoachalasia, but when they have 2 or more risk factors, malignant pseudoachalasia is a real possibility. And therefore, you need to consider additional diagnostics in the form of EOS or CT in case of 2 or more risk factors. Otherwise, this is not required. And then there's a special group of patients that have manometric features of achalasia or EGJ outflow obstruction. And these are the patients that chronically use opioids. Here's the results from a study where they compared manometries on and off opioids in the same subject. And what you can see is that EGJ outflow obstruction is much more often diagnosed in subjects on opioids, and same is true for achalasia type 3. And so if you look at these examples, you can see that chronic opioid users often have abnormal esophageal body contractions and an abnormal LES relaxation. And so you have to be very careful in interpretation of high resolution manometry in opioid users. Preferably stop the opioids 24 hours in advance, which is equal to 3.5 times of the compound. So let me summarize the current diagnosis of achalasia using Chicago version 4.0. There is achalasia when there is an abnormal high median IRP and absent peristalsis. Changes in Chicago 4 compared to version 3 are that the IRP of more than 15 in upright position also qualifies as achalasia. There is an introduction of so-called inconclusive achalasia diagnosis, where there's absent peristalsis but a borderline IRP or some remaining peristalsis. And in these cases, as you could see on the right, you need to do additional testing in the form of a time barium esophagram or FLIP. And finally, always measure off opioids in order to avoid opioid artifacts on manometry. And with this, I'd like to thank you very much for your attention.
Well, hello, my name is Dustin Carlson of the Esophageal Center of Northwestern Medicine. It's my pleasure today to talk with you about the manometric classification of EGJ outflow obstruction as defined by the Chicago classification version 4.0. A couple of disclosures. In Chicago 3.0, which was based on a 10 swallow manometry test protocol in a single position, the classification of EGJ outflow obstruction was reached when the IRP was elevated, but peristalsis was present such that criteria for an achalasia subtype was not met. One limitation was the substantial weight held by the single metric, the IRP, when peristalsis was not otherwise present, and thus not meeting criteria for achalasia. Additionally, the EGJ outflow obstruction classification does not represent a unique esophageal disorder, but instead a manometric pattern that encompasses a heterogeneous spectrum of esophageal motor function, and is demonstrated here by the array of contractility patterns potentially observed across this classification. And more importantly, this EGJ outflow obstruction classification encompasses a heterogeneous spectrum of clinical diagnoses. Achalasia is included among this clinical differential diagnosis of EGJ outflow obstruction. And whether it's called variant achalasia, early achalasia, or evolving achalasia, it may clinically represent this important esophageal diagnosis, achalasia. However, as demonstrated by this study from the Amsterdam group, as well as several other independent studies from other groups with similar findings, a relative minority of patients with the manometric classification of EGJ outflow obstruction warranted LES-targeted treatment, and few will truly evolve to achalasia, at least within several years of follow-up. So beyond achalasia, there are other potentially clinically relevant and actionable abnormalities that can be suggested by the manometric EGJ outflow obstruction pattern. This can include subtle mechanical obstructions, extraluminal compression, so this may be more rare than initially suggested, hiatal hernia, and additionally, the effect of chronic opioids and the associated potential for secondary motor dysfunction is of interest and a potential factor here. But on the other end of the potential clinical spectrum is normal esophageal motility, in which case the elevated IRP may be related to pressure artifact. It's estimated this likely commonly occurs and may involve a third or more of patients meeting the manometric EGJ outflow obstruction classification. In a nice ex vivo study led by Arash Babai, this demonstrated that various perturbations can induce HRM pressure artifact, with angulation of the catheter in particular, potentially generating significant degrees of alteration in the pressure readings. Overall, performing invasive and irreversible interventions, such as LES myotomy, among all patients with the manometric classification of EGJ outflow obstruction would be inappropriate. But yet, it's also important to detect the clinically relevant and potentially actionable abnormalities that are reflected by this manometric pattern. Thus, refining the EGJ outflow obstruction classification was identified as an important goal throughout the Chicago classification 4.0 development process. With the expansion of the test protocol, EGJ outflow obstruction was defined in Chicago 4.0 when the IRP was elevated in two positions, that is both the supine and upright patient positions, in addition to having peristalsis present, such that diagnosis of achalasia was not reached. Thresholds for IRP elevation differed by manometry assembly, patient position, and test maneuver, and thus appropriate thresholds should be reviewed and applied. Additionally, the presence of intrabolus pressurization was deemed necessary in more than 20% of supine swallows. However, even with this expansion of the definition from 3.0, in 4.0, EGJ outflow obstruction was still labeled as a manometric pattern of unclear clinical significance, and that a manometric diagnosis of EGJ outflow obstruction is always considered clinically inconclusive, and this carried a strong group consensus recommendation. Thus, the recommendation to reach a conclusive diagnosis of EGJ outflow obstruction required both relevant obstructive symptoms, or dysphagia or chest pain, and additional testing beyond manometry with either a time barium esophagram or functional luminal imaging probe, FLIP, to support obstruction. However, there were several additional manometric components that are included for providing complementary support for identification of relevant EGJ outflow obstruction. These included outflow obstruction with elevated IRP and pressurization during the rapid drink challenge or with a solid test meal. Additionally, pharmacologic challenges with either amyl nitrate or CCK could be considered if available, as they may help detect abnormal EGJ function. It's also worth noting that the solid test meal and the pharmacologic provocation studies were suggested for possible application if the standard test protocol did not detect an esophageal outflow obstruction, but clinical suspicion remained high. If an isolated outflow obstruction was detected in this scenario, further evaluation for a mechanical obstruction was recommended. Additionally, the peristaltic pattern, that is spastic, hypercontractile, ineffective, or normal, per the definitions applied to peristaltic disorders, should also be included in the description of EGJ outflow obstruction. This, as well, could potentially help in determining the clinical relevance of the manometry. To further review some of the specific criteria, intrabolus pressurization is a required finding to support the classification of EGJ outflow obstruction. There was some debate as to how best to measure this. However, the approach of simply utilizing the isobaric contour tool allows this pattern to be fairly recognizable when it's greater than 20 millimeters of mercury. An atrium assembly with impedance, if available, further improves this ability to detect the presence of bolus and thus measure intrabolus pressurization. The other requirement to meet the EGJ outflow obstruction classification in 4.0 was that the IRP elevation persisted in both positions of the manometry test protocol. The change in patient position potentially offsets some of the problematic HRM pressure artifact, and thus when the IRP is normalized in the second position, the presence of a true EGJ outflow obstruction can likely be excluded. We can see in this example that a vascular artifact becomes readily identifiable and occurs outside of the EGJ region when transitioning to the upright position. Further, in the study referenced here that used retention of barium esophagram as the outcome, 94% of patients that had IRP normalized in the second position, upright, also had a normal esophagram. This provided a very high negative predictive value. However, it should also be noted that normal esophageal clearance on esophagram remained a common finding when IRP elevation persisted in both the upright and supine positions. Thus, the finding of the two IRP elevations should be viewed as necessary but not sufficient criteria to reach a conclusive diagnosis. Moving on to additional HRM findings that can help add to the overall impression regarding potential for relevance of EGJ outflow obstruction. 4.0 recommends including the description of the peristaltic pattern in the setting of EGJ outflow obstruction. This is readily available in the standard test protocol and may also help support a potential likelihood for a primary motor disorder, such that it's higher if there are spastic features and potentially lower if it's normal peristalsis. In the setting of normal peristalsis, even supported by the presence of compartmentalized pressurization, this would raise suspicion for potential mechanical obstruction. However, this also comes with the recognition that both spasm and hypercontractility may occur secondarily to mechanical obstruction. Additionally, the rapid drink challenge can provide additional support or not to the presence of a true outflow obstruction. The rapid swallows induce a profound LAS relaxation in health, whereas EGJ pressure remains elevated in outflow obstruction and may be further accompanied by bolus pressurization, as seen in the example here from a patient with EGJ outflow obstruction and suspected achalasia. We looked at applying the rapid drink challenge in patients with manometric EGJ outflow obstruction using a stepwise approach somewhat similar to the eventual construct described in Chicago 4.0. Again, using retention as a barium esophagram as the outcome, we found that while obstruction on rapid drink challenge, defined by an elevated IRP and panesophageal pressurization, carried some predictive value to support the presence of a relevant obstruction, there still remained a fair degree of uncertainty following this application. Another test maneuver, the solid test meal, can also be utilized to support the presence of an EGJ obstruction, with notable work from Mark Fox and colleagues. The standardized test meal reflects more of a real-world scenario than small volume liquid test swallows and can detect abnormalities that may not be appreciated with single water swallows. As seen in this example here of the two study components from the same patient, in which within the single water swallows, a classification of normal esophageal motility was reached, whereas with the standardized test meal, outflow obstruction with elevation in IRP and compartmentalized pressurization is observed. Additionally, patient symptoms are more likely to be elicited during the standardized test meal. This provides the opportunity to observe the manometric abnormality that is associated with symptoms. This study demonstrated that in 151 of 750 patients, so 20% of the study cohort, a new diagnosis of EGJ outflow obstruction was assigned based on the standardized test meal, beyond that assigned with the single water swallow classification. Thus, the standardized test meal may detect abnormalities not appreciated on the single water swallows, in addition to also providing the symptom association with manometric findings. The balance with test specificity also needs to be considered, and in the scenario in which deglutitive LES relaxation appears normal on single water swallows and obstruction isn't covered by a solid test meal, the possibility of a mechanical obstruction should be readdressed, particularly if obstructive HRM findings are associated with reproduction of patient symptoms. This likely entails the use of adjunctive testing and potentially relatively cautious treatment approaches. Pharmacologic challenges with either amyl nitrate or CCK are also potential maneuvers to lend support in determining the contribution of LES dysfunction to the EGJ outflow obstruction classification. This has been supported by elegant work from Arash Babai and colleagues. As an example of application, a response to amyl nitrate that involved reduction in the IRP to lower than the deglutative IRP supports that the EGJ outflow obstruction is related to LES dysfunction, i.e. potentially achalasia. However, if the amyl nitrate IRP remains similar to the deglutative IRP, an unresponsive test, this supports more that the EGJ outflow obstruction is likely secondary and perhaps a mechanical obstruction. However, overall, while consistent HRM abnormalities reflecting EGJ obstruction provide an increase in probability for presence of a relevant outflow obstruction, some uncertainty remained, and thus the recommendation was to confirm with non-HRM tests of either a time barium esophagram or FLIP to reach a conclusive diagnosis of EGJ outflow obstruction. With time barium esophagram, the timed protocol allows for a standardized assessment of esophageal liquid retention, while incorporation of a solid bolus, such as a barium tablet, adds an additional component of a functional assessment. Thus, as seen in this example, the EGJ outflow obstruction supported by the presence of elevated IRP in the supine and upright swallows, as well as with the rapid drink challenge, can be reliably confirmed with a significant retention observed on TBE. At 5 minutes, as shown here, there's a 21 centimeter column height. Additionally, the morphologic appearance of the esophagus demonstrates the persistently narrowed appearance of the EGJ, as well as a corkscrew conformation of the esophageal body. Altogether, this helps support a clinical impression of spastic type achalasia. The functional luminal imaging probe, or FLIP, assesses esophageal luminal diameters and distensibility. Distensibility being the relationship between luminal dimensions and distensive pressure. This typically involves a test performed at the time of sedated endoscopy. In the setting of EGJ outflow obstruction pattern on manometry, if FLIP demonstrates reduced EGJ opening, such as that with an EGJ distensibility index less than 2 and a maximum EGJ diameter less than 12, this may confirm the presence of EGJ obstruction. Conversely, however, a finding of normal EGJ opening on FLIP, that is an EGJ DI more than 2 and a max diameter greater than 16 millimeters, can effectively exclude the presence of a clinically relevant outflow obstruction. We'll have some data that is hopefully impressed by the time this airs, and that will further support the FLIP approach and ideal thresholds. In conclusion, an important goal of Chicago Classification 4.0 was to refine the EGJ outflow obstruction classification to help improve identification of clinically relevant abnormalities. This involved the requirement of IRP elevation in 2 patient positions with single liquid swallows, as well as the presence of intrabolus pressurization. Additionally, this can be complemented by support from additional HRM maneuvers, such as the rapid drink challenge, solid test meals, and potentially a pharmacologic challenge. However, given potential for ongoing diagnostic uncertainty, it remained recommended that to reach a conclusive diagnosis of EGJ outflow obstruction, additional supportive testing beyond manometry with either time barium esophagram or FLIP should be pursued. In general, a cautious and conservative treatment approach should also be applied, potentially stepping up therapy as needed. And overall, the EGJ outflow obstruction pattern on manometry may remain a potentially challenging clinical scenario, and in some cases, all three tests, manometry, time-varying massophogram, and FLIP, may be needed to collectively incorporate to reach a confident diagnostic clinical impression. Reaching that confidently confirmed diagnostic impression remains essential, particularly before pursuing invasive and irreversible treatment options. Thank you, and we'll certainly look forward to taking questions and discussion.